Welcome back to the monthly IJGC Conversations, the June Editor's Choice. Today, we're diving into some recent publications that caught our eye, covering topics from cervical cancer surgery to managing smooth muscle tumors and understanding molecular patterns in endometrial cancer. I'm Louisa Proppe from the University Hospital Münster in Germany.
I'm Sofia Bigardi from the University Hospital of Padova in Italy.
And I'm Marina Rosanu from the European Institute of Oncology in Milan, Italy.
Let's kick things off with a paper focusing on changes in surgical practice for early-stage cervical cancer in the US. It's titled Modified Radical Hysterectomy for Stage 1B1 Cervical Cancer, Assessment of Temporal Trends and Oncologic Outcomes in the United States by Koji Matsuo from the University of Southern California.
This article really highlights the ongoing shift toward less radical surgery for early-stage cervical cancer. The objective was to look at how often modified radical hysterectomy is being used for stage 1B1 tumors 2 cm or smaller and see how the outcomes compare to more traditional radical hysterectomy.
And they used a large database, the National Cancer Database, looking at over 2,900 patients between 2010 and 2020. That's a significant cohort.
Exactly. What did they find regarding the trends in surgery?
They observed a statistically significant increase in the use of modified radical hysterectomy from 2013 to 2020. It was still less common than radical or simple hysterectomy overall the study period, but the trend was upward.
What I found interesting was the oncologic outcomes. They compared radical, modified radical, and simple hysterectomy. They looked at factors like lymphovascular space invasion and pathologic nodal metastasis, and those rates were actually similar across all three groups.
Right, suggesting that for this specific stage and size, the tumor biology might be comparable regardless to the initial surgical approach within these categories.
And the most striking finding was the overall survival. The 5-year overall survival rates were very close, 96.6% for radical, 96.3% for modified radical, and 95.8% for simple hysterectomy. Their multivariable analysis also indicated that neither modified radical nor simple hysterectomy were associated with decreased overall survival compared to radical hysterectomy.
This aligns with the broader movement towards tailoring treatment for low-risk disease. However, it's worth noting a sensitivity analysis mentioned that for patients aged 50 or older, modified radical hysterectomy was statistically inferior to radical hysterectomy, though they recommend external validation for this finding.
Good point. So the conclusion supports that modified radical hysterectomy may not be associated with worse overall survival for this specific stage and size, but they stress the need for further investigation, especially outside the low-risk criteria.
It's a hypothesis-generating observation from a large real-world dataset. It reinforces the idea that prognosis for clinical stage 1B1 cervical cancer is generally favorable, around 95% at 5 years.
Given the retrospective nature and database limitations, like not always having details on surgical margins or depth of invasion, prospective studies are definitely needed to confirm these findings and refine patient selection.
Absolutely. It adds the growing body of evidence supporting less radical surgery for carefully selected patients, but highlights the need for more data on long-term outcomes and patient factors like age.
Moving to a different area, we have a review article discussing a challenging type of uterine tumor, particularly when considering fertility. The paper is titled Fertility-Sparing Approach for Uterine Smooth Muscle Tumor of Uncertain Malignant Potential by Giorgio Bogani from the Fondazione IRCCS, Istituto Nazionale dei Tumori.
This addresses STUMP, or smooth muscle tumors of uncertain malignant potential. These tumors are diagnostically tricky because they don't clearly fit as benign or malignant. Hysterectomy is often the standard treatment, but many stumps are discovered incidentally during a myomectomy done for presumed fibroids.
Which is a major issue for younger women who want to preserve their ability to have children. This review specifically looks at fertility-sparing treatment options.
It's a systematic review pulling data from 9 retrospective studies totaling 327 patients. They compare outcomes for patients treated with myomectomy versus hysterectomy.
Key findings show that overall recurrence rates were similar between myomectomy and hysterectomy groups, 13.2% versus 9.5% respectively, though this difference wasn't statistically significant.
Yeah, however, they did find that patients treated with myomectomy were more likely to experience local stump recurrences compared to those who had hysterectomy. It was 11.9% versus 4.1%.
Right, but crucially, myomectomy didn't seem to increase the risk of distant recurrence or the recurrence as a sarcoma.
And for those concerned about fertility, the study found that 38.8% of patients who desired conception achieved at least one pregnancy after myomectomy. Importantly, pregnancy was not associated with an increased risk of recurrence.
That's a really encouraging finding for patients hoping to preserve fertility.
Based on this data, the authors suggest that myomectomy may be considered as a safe and effective alternative for women who want to preserve their childbearing potential.
They emphasize the importance of centralization, expert pathology review, and multidisciplinary discussion in a referral center due to the diagnostic challenges of stump. Diagnosis can be difficult and there's known variability among pathologists.
It sounds like while myomectomy is a viable option for fertility preservation, patients need to be counseled about the risk of local recurrence. And they noted that most recurrences occurred after 24 months, suggesting that there's a potentially safe window for pregnancy.
Yes, and the current standard of hysterectomy isn't actually based on high-level evidence, making these findings even more relevant. They call for more multi-center prospective registries to gather better data.
The review also briefly touches on the difficulty in diagnosing stump preoperatively using imaging alone and the potential future role of molecular classification or genomic profiling for risk assessment.
Which transitions us perfectly to our final article, focusing on molecular classifications in another gynecologic cancer.
This next paper delves into the world of molecular subtyping in endometrial cancer, specifically looking at patients with low volume lymph node metastases. It's titled The Role of Molecular Classification in Endometrial Cancer, a focus on patients with low volume metastases, a retrospective multicenter study and literature review by Gabriela Schivardi from Mayo Clinic and European Institute of Oncology.
This is a timely topic, especially with the recent changes to the FIGO staging system that incorporate molecular classification and distinguish different types of lymph node involvement.
Exactly. Low volume metastases refer to isolated tumor cells, which are 0.2 mm or less, or micrometastases, which are greater than 0.2 mm up to 2 mm in lymph nodes. With increased use of sentinel lymph nodes biopsy and ultrastaging, we are finding this more often, but their prognostic significance and how molecular subtypes fit in has been less clear.
This was a multi-center retrospective study that included 134 patients with low volume metastases who also had molecular characterization. They used the standard four molecular classes: polymutated, mismatch repair deficient, p53 abnormal, and non-specific molecular profile or NSMP.
What did they find about the distribution of these molecular subtypes in this specific low-volume metastasis group?
NSMP was the most prevalent class, making up over half the cohort, 58.2%. MMRD was the next largest group, 27.6%, then P53 abnormal, 11.2%, and polymutated tumors were notably rare, 3.0%.
That finding about the rarity of polymutated tumors in the low volume metastasis setting aligns with their previous work and other limited studies.
And how did molecular classification relate to recurrence risk in this cohort?
This is where it gets interesting. In this study, focuses on low-volume metastases, they found no statistically significant difference in recurrence-free survival among NSMP, MMRD, and P53 abnormal molecular classes.
This suggests that for this specific subset of patients with only low-volume lymph node spread, the molecular subtype on its own wasn't a strong predictor of recurrence.
So, what was predictive of recurrence?
Traditional pathological factors were confirmed as important predictors, specifically micrometastases compared to isolated tumor cells and lymph node vascular space invasion, LVSI, were independently associated with recurrence. Positive peritoneal cytology was also associated with recurrence.
The implication here is that while molecular classification is crucial for broader endometrial cancer management, in patients with low-volume lymph node metastases, clinical decision-making should still heavily integrate established pathological risk factors like the size of the metastases and the presence of LVSI.
It sounds like a call for layered approach. Molecular data is valuable context, but doesn't replace the importance of these specific pathological details in low volume setting.
Exactly. It highlights that the prognostic role of molecular classification might differ depending on the stage and extent of disease.
Like the stamp paper, they also acknowledge limitations, such as the retrospective design, potential variability in molecular analysis across centers, and a limited number of recurrence events which could impact the statistical power. They also couldn't stratify the NSMP group by estrogen receptor status, which other studies suggest is important for risk in that subgroup.
So, more data, ideally prospective, is needed to fully understand the interaction between molecular subtype and these pathological factors in low volume disease.
So these three articles give us a great snapshot of ongoing research in gynecologic oncology. We are seeing advancement in surgical techniques for cervical cancer, a push towards fertility preservation in stump, and a more nuanced understanding of molecular classification in endometrial cancer.
They all point towards the need for individualized patient care, careful consideration of risk factors, and the importance of multidisciplinary discussions.
And the consistent call for more large, prospective, multi-center studies underscores how much we still need to learn to optimize treatment for our patients.
Absolutely, it's an exciting time in the field, with research continually refining our understanding and improving patient outcomes.
Definitely.
Thanks for joining us today.
Thanks to our listener for tuning in.
We'll be back soon with more updates from IJGC.